Thank you. Thank you for the introduction. And good afternoon, everyone. And thank you for joining us today. And as you said, my name is Angeline Kim, and the headache neurologist at Hawaii Pacific Neuroscience. So I'm excited to talk about the primary headache disorders and give you a practical, clinically focused overview today. So this session kind of builds out on my last lecture when we reviewed the secondary headaches and when to pursue urgent workups. And today, where our focus is focused on primary headache disorders, where the headache itself is the disease. I have a financial disclosure, and Dr. Chen just reviewed all these the objectives today. So for the time purposes, so we will proceed. Okay. So let's start with where all the diagnostic reasoning in headache begins, which is the ICHD, the third edition right now. It is the International Classification of Headache Disorder at the standardized headache diagnosis. It is extremely helpful for anyone in medical field to evaluate headaches. And I always encourage like any physicians or any like medical providers to use it as a reference tool, as this is easily available online. And it's especially helpful when the headache semiology is not like clear, and then maybe there's some mixed features. So it'll be very helpful to reference tool. So primary headache disorders fall into, I would say, three big categories, like migraine, tension time headache, trigeminal autonomic cephalalgias, and other primary headache disorders are much rare and not easily seen. So we're going to focus on those first three today, and we'll walk through each one. So migraine. The first is migraine. Migraine is incredibly common and also almost like most common headache disorder you will encounter in medical setting. It affects 1 in 6 adults in the United States and more than 1 billion people globally. And it is one of the top contributors to disability worldwide and ranked as the third leading cause of disability among the neurological conditions. And about 40% of patients in the United States report the moderate to severe functional disability during attacks. And many people, it affects the work, relationships, and mental health as well. The migraine is not just like a pain disorder. The exact pathophysiology is still not completely fully understood. However, we know that it is a complex hypersensitive brain network disorder. And multiple reasons are involved. The hypothalamus, brainstem, cortex, trigeminal vascular systems are examples. And we found out that the certain proteins like CGRP and PCAPs play a significant role as well. So let me break down the major like components. So first is hypothalamus. The hypothalamus shows abnormal activations up to 48 hours before the pain phase begins. That this lines up with what patients often describe as like cravings, like yawning, mood changes, or neck stiffness as a prodrome symptoms. And for patients who experience aura with migraine, the aura is, we're going to talk about it later, but it is a recurrent, fully reversible neurological symptoms. Like it could be visual, sensory, or other like motor. There are different types of it, and that usually precedes the headaches. And the underlying event is thought to be the cortical spreading depression mechanism. This is a kind of a slow wave neuronal glial depolarization that travels across the cortex. And it can activate the trigeminal nociceptors and create a basis for aura symptoms. And actually, even in like migraine without aura, similar intrinsic brain activity may contribute to pain as well. The trigeminal vascular system is actually the central to migraine pain, and the trigeminal nerves innervates the meninges and the cerebral vessels, like arteries. And during the attack, these nociceptive like fibers release CGRP. And then the CGRP, the calcitonin gene-related peptide, the type of protein that drives the vasodilation, mast cell activation, and neurogenic inflammation as well. And this is why CGRP targeted medications can be effective to relieve the migraine symptoms. Um, yeah. And then, as migraine becomes more frequent, the central sensitization can develop with increased excitability in the thalamus and different types of the cortex. And patients may describe that like a scalp tenderness or allodynia, and persistent light and sound sensitivity. And medication overuse can worsen this process of chronification. So it's important to recognize and address it early. And beyond that, and then beyond CGRP, which was one of the more recent mechanisms that we found, there's another newly discovered important pathway, is the PACAP, the pituitary adenylate cyclase activating polypeptide. And this is a different protein, and we found out that this infusion of this protein can provoke migraine, and it seems to be independent from the CGRP pathway. So it is one of the main like future targets for migraine therapies. Going back to the ICHD criteria and like for the migraine, migraine is categorized into like migraine without aura or with aura or by the frequency, episodic or chronic. And chronic migraine refers to more than 15 or more headache days per month, and eight or more than eight migraine days per month for more than 3 months. And then let's look at the actual criteria. What is actually considered migraine? So migraine, you have to have at least 5 attacks, and the duration is around 4 to 72 hours. And then you have to meet two out of the four characteristics: unilateral location, pulsating quality, or moderate or severe pain intensity, and is aggravated by physical activity or causing the avoiding just like normal like activities like walking, climbing stairs. And during the headache, you have to have one of this, either nausea or vomiting, or you don't have to have a photophobia, but if you're gonna have it, you have to have both photophobia and phonophobia. And with the migraine, aura can also happen in a subtype, like a migraine with aura. And as I briefly mentioned, it is you have to meet a certain criteria, and there are different types. It could be visual, sensory, speech or language, motor, brainstem, and retinal. The difference between retinal and visual is bilateral eyes, like the retinal is just one eye. And at least 3 out of the 6 characteristics have to be met. And those are the followings. At least one aura has to spread, so it has to be like evolve in over 5 minutes. And 2 or more aura symptoms occur in succession. So for example, having the like tingling sensation is one side of the arm, and then followed by the visual kaleidoscope vision. And then each individual aura symptoms last between 5 to 60 minutes, or at least one aura is unilateral when one aura is positive, which is additional symptoms rather than like lack of symptoms. So for visual aura, it's more like kaleidoscope vision, squiggly lines, colors, dots, rather than just like loss of vision. And also the last one is when aura is accompanied or followed by headaches within 60 minutes. And and there's a specific type of aura called brainstem aura, which we think is clearly originating from the brainstem, but not motor weakness. So what type of the aura is that? So you have to do 2 out of these symptoms: dysarthria, vertigo, tinnitus, hyperacusis, diplopia or ataxia, and also decreased level of consciousness like confusion or drowsiness that meets a GC score less than 13. And then also no motor or retinal symptoms. And there is a type of a migraine with aura, which is hemiplegic migraine, which comes with the fully reversible motor weakness, but this one also should have uh, the other fully reversible visual or sensory or speech symptoms as well. Okay, so let's look at some migraine treatment briefly, which can be a whole different lecture, but so I'm gonna try to simplify that. And the treatment falls into like three big buckets. One is acute medication that to be used during the attack. This preventive medication to prevent the headache frequency. I mean, to prevent the headaches and lower the frequency and severity. And then the behavioral lifestyle modification, which is also very important. Acute medication can include like NSAIDs, triptans, GPANs, which is the CGRP small molecule antagonist, and antiemetics can be used. The things to remember is like we are not prescribing opioids or barbital because of dependency issues and also has a high risk of the medication overuse headache. Prevention options can include anticonvulsants like topiramate, valproate, beta blockers like propranolol, metoprolol, or atenolol, and TCAs like amitriptyline or triptyline, SNRIs, especially the venlafaxine. There's CGRP small molecules, preventatives like atogepant, but also monoclonal antibodies, which are monthly injectables, are available. And the Botox is also FDA approved for chronic migraine prevention. Behavioral lifestyle modifications are also very important for to give as an education for the patients. So migraine brains, we always want like a regular routines, like good quality sleep is important, regular exercise, hydration. Also, underlying any mood conditions also needs to be resolved, and stress management. And if there's any certain triggers, they should be avoiding them. In more detail, let's talk about triptans a little bit. So, although there are newer therapies out there, the triptans are still effective and safe for most of the patients. A systemic review of observation studies show that there is actually no associations between triptan use and risk of vaso-occlusive cardiovascular events, although there are only like four relevant studies were identified. Um, Though still, we are trying to avoid in the high cardiovascular risk patients, like ischemic stroke, CAD, like ischemic cardiac disease or uncontrolled hypertension, and also certain migraine types, because we think that it could increase the risk of infarction, like for example, like with the focal deficits with migraine, like a hemiplegic migraine or migraine with brainstem aura. And we get these questions a lot about the serotonin syndrome risk. So there have been some concerns of combination with like of the triptan with like SSRI or SNRI. However, the added risk of serotonin syndrome appears to be like really minimal, like almost non-existent. So the triptans can be used with people with SSRI and SNRI in most cases, and we just prescribe with the education to monitor any slight symptoms of the increased like serotonin. And I would like to briefly mention about my medication overuse headache. It is actually considered a secondary headache that worsens the pre-existing primary headache disorder from overusing the acute medications so very often. And overuse is defined as 10 or more days per month over 3 months for ergotamines, triptans, opioids, and combination analgesics like Excedrin. And for acetaminophen and NSAIDs, more than 15 days per month for 3 months. And I also like to touch the subtype of the migraine, which is menstrual migraine. And menstrual migraine is a migraine in women that occurs day -2 to +3 days of menstruation in at least 2 out of 3 menstrual cycle. It is very common and it is believed to be caused by natural estrogen drop right before the menstruation. And there are two different types. One is pure menstrual migraine, with and without aura. These patients have menstrual migraine and the migraine only in those cycles. And menstrually related migraines are they do have those menstrual migraine on, and then also have days outside of the menstrual cycle as well. And menstrual migraine can be more resistant and harder to treat and be, and then the short-term prevention can be used for like longer lasting triptans for such as like robatriptan and naratriptan and followed by and then the evidence followed by like maybe the zolmitriptan and NSAIDs during that time like twice a day for those like 4 to 5 days can be used as well. In some cases, like hormonal strategies like extended cycles of estrogen supplementations or contraceptives can be used in like select patients. But we have to be careful with the estrogen in patients with migraine with aura because with aura and then estrogen both can increase the clotting risk, so therefore increase the risk of stroke a little bit. And actually, at our HPN, we are doing the clinical trial of the ubrogepant, one of the CGRP antagonists, the small molecule for the menstrual migraine prevention. So I'm excited to see what it will show, and then the and then migraine prevention therapy options will whether it will like expand. Okay, so let's move on to the second type, which is a tension type headache. And tension type headache is actually the most common primary headache disorder. You will see in everywhere, but not in the medical setting because usually the severity is less than migraine. And then a lifetime prevalence in general population can range from like 30% to 78%, depending on the study. And pain mechanism is believed to involve the peripheral sensitization of the myofascial nociceptors. And with the persistent stimuli, it can also lead to central sensitization. And lifestyle review is important to see if there's any other factor that's triggering the tension type headache, and that's same for the migraine as well. And the diagnostic criteria wise, it's like a big range of the duration from the 30 minutes to 7 days. And at least two of the following have to be met. One is bilateral location and pressing or tightening like a band-like quality, but not pulsating, mild or moderate intensity, and it is not aggravated by the routine physical activity. And it doesn't usually involve nausea or vomiting. Also, you can have a photophobia or phonophobia, but not both at the same time. The different types are based on the frequency. So the chronic is easiest to understand. The chronic is occurring more than 15 days per month for more than 3 months, so more than like 180 days per year. And then the episodic can be divided into infrequent or frequent. So infrequent is at least 10 episodes in but less than 1 day per month. So the total is less than 12 days per year. Frequent episodic is 12 to 180 days per year. The tension type headache treatment wise, compared to migraine, there is less evidence-based treatment for tension type headache, but acute headache treatment can be NSAIDs or acetaminophen to begin with, and prevention therapy usually relies on the TCAs, especially amitriptyline, and also like antidepressant class like mirtazapine, venlafaxine could be used and show some efficacy. Non-pharmacologic wise, CBT relaxation techniques, biofeedback can be used, but like postural correction, dental guards shouldn't be. There's some limited evidence for that. And again, no barbiturates and opioids due to the risk of overuse, and then also not that great in the long-term like headache treatment. Okay, so we're moving on to the third primary headache disorder type called trigeminal autonomic cephalalgias. And this type of headache includes four different types of headaches. cluster headache, paroxysmal hemicrania, Sanct or SUNA, and then hemicrania continua. They all share the same features of severe unilateral pain, and it's usually side-locked. They don't usually change the size, and usually V1 distribution is most severe. And they have a prominent autonomic symptoms on the same side as the pain that include the tearing, like a redness in the eyes, like watery eyes, watery nose, or the ptosis or miosis, the pupil changes. And it's usually compared to like migraine or tension type, it could be shorter lasting and a very stereotyped attacks. Sometimes people can have more than one types, and typical migraine aura can be seen rarely, but with the TACs. So we're going to start with the cluster headache. It causes a really severe orbital temporal pain, but the duration is about to 15 minutes to 180 minutes, of up to 3 hours. It can happen once or up to 8 times per day. And it causes like a lot of agitation, which is distinctive. And it is one of the rare like headache emergencies in the primary headache disorder world because it is sometimes called as a suicide headache because it brings a really high severity of headaches that had led to suicide in some patients in the past. So when it happens, we have to use like all the modalities that we have to help with the flare to subside. It includes for acutely like high flow oxygen and fast onset triptan, sub-Q or nasal sumatriptan or nasal zomitriptan. Um, for preventative, the verapamil has the best evidence, and also short like steroid taper orally, and the gacazinumab Emgality is actually approved for episodic uh, cluster headache prevention, but on a higher dose, so times 3 dose of the migraine dose. The next is paroxysmal hemicrania. As you can see from the name, it's a paroxysmal. It happens infrequently, and it is shorter than cluster headache. It's 2 minutes to 30 minutes. It's a high frequency, 5 times to 40 attacks per day. And then the diagnostic hallmark is that it has 100% response to indomethacin. So indomethacin is the first choice of the treatment. However, sometimes the indomethacin is very harsh on the patient's body, like the stomach wise. So it may not be as tolerable. In that case, and the treatment can like alternatives can be used with like verapamil, which is the next best one, acetazolamide, prednisone, ergotamine, lithium topiramate melatonin have been used, but not as like not as efficient or effective as the indomethacin. Thirdly, we're going to talk about the short-lasting unilateral neuralgia from headaches with conjunctival injection tearing. So it's referring to a very specific like autonomic symptoms, tearing, and the conjunctival injection of the eye. And Suna is similar, but it's just general autonomic features. And it's even shorter attacks, 1 seconds to 600 seconds. So that'll be up to 10 minutes max. And since it's very short attack, there's no acute therapy because the attack will be over. But the first line prevention therapy would be lamotrigine. And alternative include topiramate and gabapentin. The next one, the last one, is a hemicrania continua. It is very similar to paroxysmal hemicrania. However, this one, as the name says, is continuous. So it has a continuous unilateral headache, but the severity can fluctuate with flares. And this one, diagnostic hallmark again, complete response to indomethacin. And because indomethacin is really severe, since hemicrania continua patient will need a more prolonged indomethacin use, GI protection is required, and other things other alternatives can include NSAIDs, topiramate, gabapentin, rarely Botox, but again, the indomethacin is the most effective medications for it. This table kind of summarizes these different types of TACs. Uh, Basically, the what how we can tell the difference are by the duration and how frequent it happens. And then the for key features wise, the hemicranias respond to indomethacin, clusters respond to the oxygen, triptans, and and the Sanctin Suna is lamotrigine. So that's everything. So like what are the key takeaways? So once when we evaluate headaches, secondary headaches should be ruled out. After that, we can try to categorize the headaches by this ICHD-3 headache criteria because they can guide us for a certain treatment. And migraine are very common and then causing a lot of disability in the world. Uh, there are most research about it, and then there are evidence-based acute and prevented options with newer options on the line. Menstrual migraine is a type of a migraine, but in women, it's caused by the natural estrogen drop before the menstruation. So far, the best evidence is bromocriptine, meaning prophylaxis, and then the tension type headaches, which is the most common headaches. And we can start with the lifestyle routine reviews and improving that. And then there's those simple analgesics and TCA for prevention. And TACs, rare but very distinct with the shared features. And each treatment based on the type of the TAC, based on the frequency and then the duration. And also, the psychiatric comorbidity is always important to address that because it's a one brain. And if there's underlying untreated anxiety, depression, usually like those chronic headache disorder also don't improve. So those should be always addressed in all the patients as well. So, and these are my references, and that's the end. And I'll take the question.